Hello everyone, this is an interesting case of delayed initiation but dramatic response with Tecovirimat in an Mpox patient with HIV/AIDS. Mpox, caused by the monkeypox virus, is a re-emerging infection first isolated in monkeys in the 1950s and identified in humans in the 1970s. It remained largely zoonotic until the 2022 outbreak, which reported over 99,000 cases worldwide, predominantly with anogenital lesions. This is a case of a 28-year-old sexually active male (MSM) from El Salvador presented with a posterior scalp lesion and perianal vesicles of 2 weeks duration. Initially misdiagnosed as tinea capitis and genital herpes, he was treated with ketoconazole cream and valacyclovir, but the lesions did not resolve. 63 days later, he returned with worsened lesions and a new diagnosis of HIV, for which he had started antiretroviral therapy with Biktarvy. Examination showed an erythematous eroded plaque with hemorrhagic crusting on the posterior scalp and punched out perineal erosions with discharge. Mpox DNA PCR from perineal swabs confirmed clade 2 Mpox. He was started on Tecovirimat with marked improvement within 6 days and completed the course of 14 days of Tecovirimat and responded quickly. Complete improvement took several weeks to months, however, and HIV therapy was likely a contributor to complete resolution. So as you can see from the pictures, the first pictures show the lesions when he came first to the hospital in the ED, and these pictures are from 63 days after he presented to the ED. And the last two pictures are on the 6th day of treatment with Tecovirimat. His other labs, as you can see, CBC, CMP are normal, ESR 35 mm in the first hour, RPR negative, urine chlamydia gonorrhea negative, HSV1 and 2 DNA PCR negative, CMV IgM negative, HIV1 viral load was 111 copies per ml, absolute CD4 count 162, hepatitis B surface antigen and core antibody were positive, and hepatitis B viral DNA load was over 2 million international units per ml. So Mpox is an enveloped double-stranded DNA virus of the orthopox virus genus. In immunocompromised patients, particularly with advanced HIV, it may present with severe persistent mucocutaneous disease. Although this patient's diagnosis was delayed by 63 days, initiation of Tecovirimat led to rapid improvement and full recovery, supporting its therapeutic role even when started late. Standard management remains supportive care with antivirals reserved for severe cases. Tecovirimat, which inhibits the viral P37 protein to block spread between cells, is the first-line antiviral authorized under investigational protocols in the United States and Europe. While randomized trials are lacking, observational data suggest reduction in illness duration and viral shedding. This case demonstrates the aggressive natural history of Mpox and advanced HIV and highlights the benefits of Tecovirimat even after delayed initiation. There is no other case report so far in which delay was so prolonged as 63 days prior to Tecovirimat initiation. Clinicians should maintain high suspicion for Mpox in patients with such characteristic rash, particularly in high-risk population. Also, we also want to stress on the fact that vaccination should be encouraged for at-risk individuals and for travelers. Thank you so much.